Welcome to the Advancing Maternity Care podcast. I'm Kristin Tully, founder and chief scientist at Couplet Care. In this podcast, we invite maternal, infant, and family health thought leaders to share their perspectives and their work. Connecting around research and experiences is key for implementing more meaningful support for families and those who care for them. It's a joy to welcome Rose Horton. Rose Horton is a leader and advocate for maternal health equity. She has served as Director of Women and Infant Services at Emory Decatur Hospital and was the 2025 President of the Association of Women's Health, Obstetric and Neonatal Nurses. Rose has dedicated her career to transforming clinical practices and health policy. In 2022, she earned an induction as a Fellow of the American Academy of Nursing. She is founder of the Not on My Watch movement to reduce maternal mortality. Through her consulting, she equips healthcare professionals to practice respectful maternity care for every birthing person. We have shared interests, too, around promoting and protecting families through the fourth trimester. Rose, welcome.
Thank you so much. I'm so excited to be here, Kristin, and thank you for all the work that you do as well.
Thank you. Will you share more about your current work and what drives you with that?
I would love to. In 2017, I coined the hashtag Not on My Watch. And I coined that hashtag after doing some research for a presentation. I was doing the research for the hospital that I was working as an interim leader because I hadn't been working in the OB space for about 4 years. And so in preparation for the presentation, I really wanted to just be really well prepared and know what's happening in the space. So as I'm Googling, I'm seeing things that horrified me. I first learned about the death of Kira Johnson in California. That was completely preventable. I learned of the death of Lauren Bloomstein in New Jersey. That was preventable as well. And the death of Shalon Irving in Atlanta, Georgia. And you know how it is when you're Googling and researching, the algorithm. And I ended up in the ProPublica Lost Mothers page. And by that time, I was like crying hysterically and just so concerned. And I was like, what the heck? What's been happening in the past couple of years? And I was wondering, what can I do? How can I be part of the solution? And Not on My Watch was what popped in my head. And I was like, yes, within my locus of control, I will ensure that we mitigate morbidity and mortality for mothers, birthing people, and for an infant. And I remember when I did the presentation at Emory Decatur Hospital, I said to the leaders, there were probably about 250 people in the space, I said, y'all, this hashtag is going to go viral. And everybody started chuckling, myself included. I said, even if it means that it's viral around Emory Decatur Hospital. So I felt like 2017 was really a tipping point for me, that I really wanted to be part of the solution. And that really drove everything that I did as the executive leader at Emory Decatur Hospital for the Women and Infant Service line. Looking back retrospectively, I can say that we were on the journey towards equity. We didn't say it. It wasn't a banner that's saying, effective today, we're on the journey. But from that experience, from coining the hashtag and sharing it with the leadership team and getting the buy-in and the support, that was really, really lovely. I felt like we were well positioned to really make some of these substantive changes that would have an impact. And yeah, that's how it started. And I'm so incredibly proud of the work that we were able to accomplish, the outcomes that we were able to accomplish for the birthing community. And that really led me in February of 2024. It led me to be courageous and take the leap into being self-employed as a consultant because I wanted the opportunity to help other healthcare organizations achieve the same kind of results that we achieved, because I felt like it was with intentionality, that it was absolutely replicable. So that's what I'm doing now. I'm doing some consulting and lots of public speaking around many topics, but at the core of it, which now I've embraced as my life's work, is mitigating maternal and infant morbidity and mortality, and holding space for how do you create a culture that recognizes the sacredness of pregnancy, labor, and birth. So that's what I've been up to.
It's amazing. And I love the hashtag because it's about responsibility and individual responsibility and collective. And that's so powerful. Could you share more about shifting culture for, meaningful support?
Yes, I'd be happy to do that. I remember in 2019, so this was 2017, so in 2018, I made the decision to accept the position and to move from interim to a full-time position. And we started the work then, and we started with a journal article review, the leaders, and looking and hearing some stories and looking at outcomes. And that really led to us asking some questions of ourselves, how are we doing with things like that? Because in 2018, 2019, I'll be completely honest, we were not looking at our outcomes and stratifying our outcomes based on race or ethnicity or language. So we're like, okay, we need to do this. We need to start looking. So the first metric we used was based on race. And we started with looking at our breastfeeding rates. Emory Decatur Hospital, about 60% of our patients identify as Black or African American, and 18% white, about 12% Latina, and maybe 6-7% Asian. And we have a small percentage of other, which was multiracial and some, other demographic. So when we looked at our overall breastfeeding rate, it was great. Well, maybe not great. It was trending in the right direction year over year. We made the decision to become a breastfeeding friendly. Sorry, I'm having, you know what I mean?
Yeah, well, there's so many designations, and that's another interesting thing. Baby friendly, birthing friendly, mama certified. There's
Yes, so it was the baby friendly designation around the 10 tenets. I'll call them tenets for now. So we made that decision, and as a result, our breastfeeding rate was trending in the right direction. But in 2019, when we decided to look at our data stratified, our white patients had an exclusive breastfeeding rate in the 80 percentile, which was fantastic. But our Black patients, the majority of our patients, had a rate in the 40th, 50th percentile, which begged the question, why? So we started with the 5 whys and asking some questions and looking at our processes. And one thing just led to another. We were very curious, and we were very committed to solutions and to finding equitable outcomes. So as a result, we did a lot of investigation. We looked at the data in many different ways. And subsequently, we had education. We created a course called Respectful Equitable Care that was mandatory for everyone to attend, and everyone, not just the nurses, but we wanted the techs, we wanted the unit secretaries, and it was for the entire service line. So it wasn't just for labor and delivery, it wasn't just for triage, it wasn't just for mother baby, NICU, lactation. Everybody who touched the patient needed to understand what respectful, equitable care looked like. And through our process every year, we had another focus, 3.5-hour mandatory. Everybody had to attend. So we started with providing education, and then we set an expectation, and then we audited, and then we wove in accountability. So it was a full circle. It wasn't just, this is the flavor of the month. It was like, no, this is what we're going to do from now on. and we're going to be looking, and we're going to have some difficult conversations.
Okay.
And, we had some attrition along the way because there were some people who felt like they didn't want that level of accountability and that level of responsibility, that level of shared responsibility, which was absolutely fine. Where we wanted people who wanted to be part of the change, who wanted to ensure that we had equitable outcomes. But it was through a very intentional process that we were able to see equitable changes. There's a slide that I use when I talk about breastfeeding disparities that showed our data, and I said the first data looks like VTAC, because it looked just like that. But the second one, it was very, very equitable. And I love that because that's what happens with intentionality. So, yeah, I'm a big fan. I'm a big fan of setting an expectation, providing education, and really sharing responsibility and weaving in accountability. I feel like if there's any initiative that's really important to you that you want to be successful in, you need to have those clear steps so that you can be successful, and it can be hardwired and it becomes part of the culture. And yeah, I can go on and on, but I'm going to stop there.
Yeah, so visibility, like I just want to repeat back some of so understanding what's working well and where the gaps to goal so that can be known in a timely manner and actively addressed as part of an ongoing cycle. Yeah.
Exactly that. We were sharing data on a weekly basis. That's how intense it was for a time. And we would have conversations, I know, and our rounding. I did lead a rounding with our nurses and also with our patients, but with our nurses, on mother baby and postpartum, I would ask the question, hey, who's exclusively breastfeeding? And my expectation is that you will know of all the couplets that you have, who is breastfeeding. And I would ask, any concerns, any barriers that we can remove for them, how are things going? So that, as you mentioned visibility, there was definitely leadership visibility as well. The whole leadership team, that was our commitment, that we would all round on every unit, so it was a divide and conquer process so that we can ask these questions and ensure that we were helping our patients and ensuring that we were providing equitable outcomes.
That's really exciting. I've written about that our values show. And so, and I think breastfeeding is such a sacred and special and complex relationship that's a really good sort of indicator of how supportive and enabling the journey. I was going to say, the team, but like every aspect of it is so that people can achieve their goals.
Right. And that was really important to us because when we first started and we looked at our data and we were horrified, I remember we had some mandatory, at least 3 times a year, I would have mandatory meetings with all 320 people who reported to me at all times of the day so I can meet them at times that work best for them. But when we first started the process and I shared the data, the disparate data, and I would ask, why do you think the data's that bad? And there was a lot of victim blaming. There was like, oh, Black people don't want to breastfeed. Oh, it's the patient's mother, the grandmothers, they're really hard. Oh, the providers are not giving them adequate information in the clinic about breastfeeding. There was a lot of that. And it was really curious because in my heart of hearts, I knew it was more than that. I knew that we in the hospital space were contributing in some way. But it was interesting how the conversation started. So I remember our nurse scientist on our team, she's like, let's change the denominator. Let's change the denominator to everyone that we ask on admission, what's your feeding plan? And they say breastfeeding. I said, that will be the denominator because it was all at first. And so it's educational, it's them. So when we change the denominator to the patient states on admission, they want to exclusively breastfeed. And we looked at our data again, and our data was basically the same. We had to go back and ask another question. It's like, okay, y'all. So these are people who already did the education. They see the value. They've made the commitment. And an admission they want to, and on discharge they're not. What do you think the problem is? And those were the harder conversations. And I wanted the team to come up to say, yikes, I think it might be us. I think we may be contributing to that. And some groups came to it quicker, and others I had to say, we're the problems. It's us. It's us. How are we showing up for patients? Ooh, what stereotypical thinking do we have about certain patient populations and how they value breastfeeding and other things? So it was interesting. It wasn't easy, not at all. It was hard conversations, and I think oftentimes people perceive that it's easy for leaders to have these hard conversations. It is not easy. It is not desirable. I don't want to do that. But let me tell you, it's important enough that I will do it. That's why I'm called to be a leader, to have the really great, wonderful conversations, and also to have the ones that challenge us. Because at the end of the day, we're better as a result when you have somebody who will ask you those difficult questions and really encourage self-reflection, which we did a lot of. Let's look inside. Where do you think this is coming from? What are some thoughts you have about this? So that was, it was good. Necessary, not easy.
Yeah. That's what, in my line of research, it's been so helpful we film in various settings in partnership with people, sometimes in their homes, sometimes in a laboratory, and also on the postpartum unit. And then we can see what people experience. So when clinicians, for example, when they come in, do they offer a welcome? Do they introduce themselves and welcome? Do they share the purpose of their presence to do a certain assessment or to check or to ask how you're doing? And one of the key things too is, are we offering encouragement? Not just not being discriminatory and making negative assumptions about people and bringing in, for example, formula to breastfeeding family, which we see, or making hand gestures for people who speak a language other than English, like about how to wash their hair, when to call, or it's just really stunning some of the workarounds, because it's hard to get interpretation services. It's such a systems issue, but then it is felt and experienced in these interpersonal dynamics. And that's where we've seen too, right? If you can't see or reach your infant, with the minutes, then, it's been really exciting to live it myself too, but, before that and through it, to see what people navigate into, we want to address, as you've shared, what do people need to know? What do we need to feel, respected and cared for, valued? And there are a lot of things that help with that. And then we also need access to, of course, technical support, but also to be able to pick up and set down your baby however you want and need. And that's a lifetime thing, but that's something that needs active support.
No, I think you raise a really good point with the encouragement. I remember having conversations with the team, especially during the mandatory all teams meeting, as Black people do want to breastfeed. And for some Black people, just like with some white people, it's difficult, and it's really important. We talk about the energy. I talk about the energy a lot, the energy that you bring into a space. I said it's really important to bring in the energy of, I want to encourage, I want to motivate, I want to inspire. I remember some questions that felt a little bit like pushback from some of our lactation consultants around, well, we don't want to coerce anyone. And I'm like, oh, absolutely not. I think coercion I think there's a specific intentionality around coercion. They said coercion or perceived coercion. I said, I completely understand that. I said, but encouraging and supporting and using words like, I can imagine this must be difficult for you. What can I do to make this easier for you? I said, there's words that we can use to really get to that. And there's lots of barriers that we can remove. And we talked about those barriers as well. And one of the barriers, as you mentioned, we recognize, and this is so important, I just want to share a really quick story. One of our patient care techs, she was newly hired. I think she was probably 3 or 4 months in. She went to a leader and she said, you know, I've discovered something. She said, as I'm going to patient's room, and what these patients have in common is that they all want to exclusively breastfeed. She said, but in some patients' room, I see formula, and in some patients' room, I see donor milk. And as the leader is having more of a conversation and asking some more questions, the tech said, and I also feel like the Black patients are more likely to have formula and the white patients have donor milk. And I was so appreciative of that conversation, her observation, and that we've created a culture where people can speak up. And then we recognized that we didn't have a standardized process on how we have the conversation about supplementation. So it was an opportunity. And it's like, okay, well, here is a standard process. And we did education, we have a form, and it's like everybody who says that their intent is for exclusive breast milk feeding, human milk feeding, they will have donor milk. We will not offer them formula. Not that there's anything wrong with formula, I just want to say that. My sweet granddaughter was fed formula, and she's totally fine. But we wanted to ensure that in our effort to help and support our patients, because we know that breastfeeding can be difficult and challenging, in our effort to support them, that we were not providing an additional barrier or a reason to stop. So that was really important to us. And as you talk about access to the baby, quite simply, we know that our NCSV rates are rising, right? There's more C-section. And a lot of these C-sections are occurring after many days of labor. And our patients are exhausted. They're exhausted when they go to the postpartum unit. So that's why I love couplet care. I'm going to say something about it. But I love it because it's important that the patient has the ability to have access to their baby and have the freedom to do that and can do it naturally. It's all about being vigilant and looking around and saying, gee, with her laying in this position, it's like impossible for her to get the baby out of this bassinet. It's important for us to do that. And I think nurses do that beautifully, not for self-promotion, but I just want to tell you that we're having a conference. This is our third year having a Not on My Watch conference. This year, we've decided to make it a 2-day conference. First day is conference as usual. The second day is a hackathon. And the whole goal, because in my experience, in my travels around the country, and having worked in 7 different states, nurses are incredibly innovative and creative. We do so many workarounds, right? I wanted to hold space for that innovation. And Kristin, I have to tell you that I am a huge fan of couplet care. The ease of moving that bassinet and raising it and lowering it, and I just think it's beautiful. So that's like the whole reason I'm having a hackathon, because I feel like nurses have solutions and sometimes they don't have a platform to say, I have this really great idea. So I'm really excited. And along with that, I was telling you about Anna and her birthing bed, which is a beautiful, beautiful innovation, because the birthing bed has movement, figure 8 movements and other gentle movements that really help aid. What they're finding is that it really activates labor, stronger contractions and dilation. And we know that many of our patients based on the region where you work, many of our patients have continuous fetal monitoring and they have to be in the bed or they want an epidural and they can't move around. I love the innovation. So I think holding space for innovation is really important because in our healthcare system, there's many things that are working and lots of things that are not working. And I do think the people closest to the problem are almost always the best ones with the solutions. So I just wanted to do a shout out for not just nurses, but all clinicians who are innovative and creative and have a solution. I want to say I see you, I appreciate you, and please continue to drive your innovation or your recommendations forward because there's a space for it. There's absolutely a space for it. But enough of that. I just wanted to talk about that for a second.
That's so exciting. Yeah. I mean, and that's what we are all like, what do humans need? And then we have people who, what gets in the way then becomes the way. Like, how can we establish a process or, communication or a thing, whatever it is, and then share that and help then institutionalize it. So then we can improve something else. There's so many things. And so I think that this partnership of human-centered design for, what would be helpful and then working, to improve that in collaboration instead of, we don't need buy-in when we're doing it together.
Right.
Exciting.
Yeah, I love that. What gets in the way becomes a way. I'm going to use that. That's really true though, then we become socialized and this is the way we've done it for 30 years. Words that make me crazy. I'm like, well, yay. However, it's a new day. Yeah. Let's see if we can do something different.
We've talked and we published about renovating, right? Let's keep what's strong and appropriate and a good fit, and then let's restructure the rest. And like when people create it, we can undo it and then recreate. And so that's what
Absolutely.
I hope, that in addition to being a useful thing, I really hope that the couplet care bassinet is just an example of how we can listen to each other and then have the commitment, as you described, to follow through on that. And that's a lot of work, but it's, people do it every day, improve quality care. So we just want to help facilitate that.
Absolutely.
Great. Well, is there anything else that you'd like to share? I think that's really exciting about your conference, and we can put a link, or if you want to share a little bit more right now about when that is and how people can learn more, that would be great.
Oh, thank you. I would love to. So our conference is going to be October 21st and 22nd in the beautiful city of Atlanta, Georgia. And we have some amazing speakers. Last year's theme was Glimmers of Hope. Because, last year was trash and people needed a little bit of hope, clinicians needed. So this year, our theme is hope in action.
Yeah.
We need hope, but then now we need action. We need to be part of the solution, which is why we thought it'd be great to have a hackathon or innovation hub, whatever term really resonates with people. So it's going to be a 2-day event, and I'm really excited. So we have speakers. We have a couple of speakers that are CEOs in the femtech space, because I feel like, the healthcare space and the femtech space are like work in silos, and it doesn't make any sense because the femtech is created for the patients that we're caring for, right? So I'm excited about that. And we have somebody from Maven Clinic, because as we're talking about reimagining healthcare and being innovative, I was really excited that we could have that. We have Charles Johnson that's going to be speaking for us, and he's an amazing advocate for the loss of his wife, Kira Johnson. But also he has started Fatherhood Initiative, because fathers are forgotten in this space, especially Black dads. So I want to talk about his inspiration to focus on fathers and how fathers can be part of the solution. So it's very much leaning towards innovation, but also talking about the power of the clinician and the nurse. Our keynote speaker is the one and only Dr. Monica McLemore, and she is fantastic. So it's going to be pretty awesome. And I'm very, very excited about that. So I'll be happy to share a link. But I'd love to, if we have just a few minutes, I'd love to share a call to action because I think that all of us need to be part of the change. There are 5 tenets that are part of the Not on My Watch movement. And I'm encouraging everyone who's listening to this podcast to really partner with me, with Kristin and I, in these 5 tenets, because I believe that if we do these 5 things, we will significantly mitigate morbidity and mortality. And the first is that we treat everybody with dignity and respect. That's tenet number 1. Number 2 is that we listen to and we believe women. Number 3, that we provide evidence-based care. So our care is not arbitrary. It's not my opinion. It's not, I do this today and I do something tomorrow. What does the data reveal? So that means we have to look at the data. We have to do our research, right? Evidence-based care. And then shared decision-making. It's really important that we dismantle the hierarchy that we've created in healthcare, that decisions are made at the top by the physician, who's the most important person. No, I think we need to look at it in a circle, right? And the patient's in the center of our care. Shared decision making. What's important to you during your birth? What's important to you as your baby's in the NICU? What's important to you? Shared decision making, and last but not least, advocacy. We need to advocate for all women and birthing people and infants. Those are the 5 tenets. It's not super expensive. There's really no innovation needed with it. It's very foundational, yet it doesn't exist at a level that it should exist. So that's my call to action to everyone who's listening. Partner with me. Let's make this all different.
That's wonderful. Thank you, Rose. Thank you so much.
Thank you, Kristin. Thank you for the opportunity and the conversation.